and let me bring this over here. Let's see. I think I'm going to bring this, see if I can, over here. And let me see here. Oops. Okay. So I did put, you do have the PowerPoint in this for a student PowerPoint. Did you all see that? Whoever, some people like to have that. Let's see. All right. Okay, so we're going to talk about cardiac care of patients with cardiac problems, but specifically we're looking at heart failure, congestive heart failure, okay? And we're really specifically even more going towards what I would consider more chronic, you know, once it gets chronic, and how do we take care of these patients as it becomes chronic and as they get worse, okay? So your CRS patient, the clinical reasoning patient, Mr. Morales, will touch base on that patient throughout the slides. So we will see if this works, okay? All right, so, and I'm gonna, learning objectives, please go through these, okay? Our central concept is going to be perfusion, but obviously gas exchange is pretty close to another concept that we're looking at, but perfusion is what we're focusing on. What are some things that you think about when you think about perfusion? What do you think about? What types of perfusion do we think about?
Like tissue perfusion? Is that what we're talking about?
Yes. Yeah, good. And what else?
Gas exchange?
There's tissue perfusion, and what other kind of perfusion? So if you're looking at somebody and you're assessing them, how do you tell, well, how do you tell if they're centrally being perfused?
You can look at their coloration, you can assess their cap refill, you can look at their work of breathing, check their blood pressure, heart rate.
So does the cap refill on the arms or on the legs tell you if the person's being centrally perfused, or more about tissue perfusion?
Tissue.
Tissue. So that's kind of what I was going for, is just that there are two different, I don't know, even know if you really say it, I guess categories is a good word for it, right? Categories of perfusion. So you have central perfusion and tissue perfusion. Central perfusion, we're really talking about the force of the blood coming out of the heart. Cardiac output requires adequate cardiac function, blood pressure, and blood volume. So those things you have to have in order for central perfusion to be adequate. And again, we're talking about cardiac output equals the stroke volume times the heart rate, right? So when we talk about stroke volume times the heart rate equals cardiac output, it's the cardiac output then is the amount of blood being pumped out of the left ventricular on every beat, all right? I'm gonna stop saying all right, because it's, stroke volume, amount of blood ejected from the ventricle with each heartbeat, and a heart rate is regulated by the ANS, or the autonomic nervous system, sympathetic and parasympathetic. This is something, I mean, obviously it's kind of the same type slide here. Just really go back to this slide. In understanding this concept is important in understanding congestive heart failure. Why do you think that?
Miss Thorpe, I don't think you're sharing your screen.
I'm not, huh? Well, that doesn't do much good. How's that? Can you see it now?
No, it's all black.
Really? Okay, let me go back.
It says that you're, oh, now.
Is it okay now?
Yeah.
You know what?
Yes.
So, and you hear my voice and everything okay. All right. I think when we go to the videos, I may need to do something different, but do you see it now?
Yes.
Yes.
Okay. All right. Well, that helps. All right. So let's go back just up here a few slides. So again, concepts is perfusion, but the interrelated concepts is going to be gas exchange, comfort, and they say immunity. I would say gas exchange is in perfusion. A lot of you put both of those on your ATI diagnosis template. So that is correct. Here's the slide. I was wondering why you guys are like, so central perfusion and tissue perfusion. I'll just kind of run back through. When we're talking about cardiac output, equals stroke volume times the heart rate. The heart rate, so what happens with the heart rate to consider it? They say here the first compensatory response. What does that mean?
The heart rate increases to provide better perfusion.
Yes. Yes, so that's a compensatory response. Sorry. Pathophysiology to heart failure. It is a chronic health problem already in clinical, not so much this semester, obviously, but you may have in med-surg or ARU patients. But first semester, did any of you see patients that were being treated for chronic heart failure, or had it as one of the diagnoses? Maybe they weren't in the hospital for it, but that was one of their diagnoses. Do you remember? What do you think?
I've had one in the past, but not this semester.
Yeah, in my last program.
Okay, all right. Guess we're seeing more diabetes now. Okay, so left-sided heart failure. This is formally known as congestive heart failure. They kind of lumped everything together. And there's typical causes of it. Somebody with high blood pressure, hypertension, coronary artery disease, or valvular disease. Not all of the cases are going to be concerning fluid accumulation, and there are two types. So left-sided failure may be acute or chronic and mild to severe. It can be further divided into these two subtypes. Systolic heart failure is often called forward failure because the cardiac output is decreased and fluid backs up into the lungs, the pulmonary system. Because these patients are at high risk for the sudden cardiac death, patients with an ejection fraction. So this is important, and you'll see this, I've seen it some places, it's less than 30% or less than 40% is a difference in these patients. And someone with an ejection fraction of less than 30% would be a candidate to get a defibrillator, an implantable defibrillator, excuse me. In contrast to diastolic heart failure, this is heart failure with a preserved left ventricle function, and it occurs when the left ventricle cannot relax adequately during the diastole. So what does that do? When it's not totally relaxing, what do you think is happening inside with the blood and everything?
It's letting more blood into the heart, making it fill up.
Well, actually, think about it. It's not totally relaxing. So the blood is coming back in there. Can it fill with blood as much? If
Not
it's,
really. Ultimately, it's causing kind of like a form of stenosis.
right, exactly. So it's inadequate relaxation or stiffening prevents the ventricle from filling with the adequate amount of blood to give adequate cardiac output, okay? Because remember, you need that volume and you need the heart rate, to get the adequate cardiac output. I don't know why my thing is not there. So inability to pump the blood forward in systolic heart failure, decreased left ventricular, I'm sorry, I'm having a hard time talking this morning. Blood ejected from the left ventricular with each contraction. So over time, the left ventricular, the LV, I'm going to call it, becomes dilated and hypertrophied, and it is caused by impaired. It's caused basically something's happened to the heart. So the person may have had an MI. They may have problems with increased afterload or hypertension, high blood pressure, cardiomyopathy, any kind of mechanical abnormalities, something wrong with the valves can cause this to happen. The hallmark of the systolic failure is a decrease in the left ventricular ejection fraction. So when they're making any kind of diagnosis, that would be one of the things they're looking at. With diastolic failure, this is the inability of the ventricles to relax and fill during the diastolic, the relaxation phase. Decreased filling of the ventricles will result in decreased stroke volume and decreased cardiac output. So diastolic failure is often referred to as heart failure with a normal ejection fracture or a normal EF. The diagnosis of diastolic failure is made based on the presence of other heart failure symptoms with the normal ejection fracture. So diastolic failure is characterized by high filling pressures due to stiff ventricles, which results in venous engorgement in both the pulmonary and systemic vascular systems. Diastolic failure is usually the result of left ventricular hypertrophy from hypertension. That's the most common reason, or the MI, etc. Sorry, let me go back here. Okay. So right-sided heart failure may be caused by the left ventricular failure, right ventricular myocardial or a right ventricular MI, or pulmonary hypertension. So, you know, when you're studying these, just pull these apart. You might want to have a chart, or you might want to do a concept map and pull these apart so that you understand the differences. High output heart failure. Basically, the cardiac output remains normal or even above normal. And this can occur when high output failure is usually caused by an increase in metabolic needs. So think about someone who's septic, someone who has a high fever, someone who's anemic or in hyperthyroidism. This type of heart failure is not as common as the other two types. Classification and staging of heart failure. The ACC, or American College of Cardiology, and the AHA, American Heart Association, developed an evidence-based guidelines for staging and managing heart failure. Honestly, this is in your book. It can be found, but thinking about any kind of questions or anything on an exam, I would not think I would ask you this unless I provided you with the table, all right? Because that's a memorization and we don't want you just to memorize stuff. So etiology of heart failure is caused by a systemic hypertension. And again, in most cases, somebody's had an MI or a heart attack. The most common cause is structural heart changes, such as valvular dysfunction, particularly in the pulmonic or the aortic stenosis, which leads to the pressure or volume of overload in the heart. This here, some common causes of heart failure. On the one side here, you have common causes, and these are the risk factors, okay? Questions so far? Are you guys doing okay? Okay, so precipitating causes of heart failure. This is a slide meant to have you think about what's going on conceptually with these patients, okay? Why are they having low cardiac output? And these are some reasons why they might. So with anemia, what is the resulting, I don't know if I'm going to ask this right. So what results from anemia? What do you think is happening in the heart? If the tissues and centrally it's sensing that there's not enough oxygen going around because there's decreased red blood cells, what is going to happen in the heart?
The heart's going to have to work harder.
And yes, it's going to increase its heart rate. So yes, and then pretty soon it's not going to be able to keep up with the demand. You know, it affects the whole system, right? What about infection? Kind of the same thing, right? Anemia and infection. The body, so in anemia, you have the decreased ability because there's decreased red blood cells to pass oxygen off into the tissues. But in infection, what's happening with oxygen demand?
It's increasing.
Right, because the body's in distress, it's basically needs more oxygen to fight the bacteria or the virus or whatever. So oxygen demand goes up. What about the thyroid hormone, the thyroid toxicosis? What do you think happens in the heart? Kind of along the same lines, right? So too much thyroid hormone is probably going to increase the heart rate and the workload on the heart. Let's jump down. How about, what if somebody has bacterial endocarditis?
Well, that's an infection, so it would increase, or you need more oxygen demand and it would increase the workload.
Right, and since it's inside, it's having to do in the heart, it also may cause damage to the heart, right? What about someone who has a pulmonary embolism? What's going on in the heart if somebody has a clot in their lungs? I know there's more people out there than two people.
It needs to be harder.
What'd you say, Brittany?
It needs to continue to pump harder.
Yeah, it's increased workload because it's not able to get into the lungs, right? For whatever reason, some part of the lung is being blocked off from this clot. Okay. So in general, heart failure has to do with ventricular failure, which leads to a low blood pressure, which leads to cardiac output, which leads to poor renal perfusion. And then that sets you up for a whole other set of problems. It can be abrupt or it can be slow onset. And it does have, the body has compensatory mechanisms that mobilize in order to maintain adequate cardiac output. So what do the words mean, compensation and decompensation? We kind of talked about compensation. What about decompensation?
When the body can no longer make changes to compensate for whatever's going on, right?
Good, yeah, good. So when cardiac output is insufficient to meet the demands of the body, we hope, and there are compensatory mechanisms that work to improve the cardiac output. These mechanisms may initially increase the cardiac output, right? It's going to well, we'll just keep going. But so eventually, though, they have a damaging effect on the pump function because the heart can't keep up. So major compensatory mechanisms are going to be the SNAs, the sympathetic nervous system stimulation, the RAAS, or the renin-angiotensin system is activated. So in heart failure, stimulation of the sympathetic nervous system as a result of tissue hypoxia represents the most immediate compensatory mechanism. Stimulation of the adrenergic receptors causes an increase in the heart rate. So the beta adrenergic effect is to increase the heart rate. And blood pressure from vasoconstriction, so alpha adrenergic, the vessels constrict, blood pressure goes up. Because cardiac output is the product of heart rate and stroke volume, an increase in the heart rate results in an immediate increase in cardiac output. But this is limiting, right? So it only can do so much if it becomes, the heart rate becomes so high that during the diastolic phase, the filling time, basically the blood in the heart is limited in filling. And it also isn't passing the oxygen to the tissues. So one of the, let's see here, I don't want to lose out. So one of I'm just gonna, oh, sorry. So here, I believe this one is from your Iggy book. This is showing the compensatory mechanisms in heart failure. So looking at this, what do you see here? So what do we start here? So myocardial dysfunction. So someone's had an MI, ischemic heart disease or hypertension, which causes a decrease in cardiac output, which causes a decrease in systemic blood pressure. So the baroreceptors inside are activated. So left left ventricle, the aortic arch, and the carotid sinus. Inside, those baroreceptors in those areas are activated, and the vasomotor regulatory centers in the medulla are stimulated. So then you can see how this just starts a cascade of effect. So you're going to get vasoconstriction, which is going to help increase the afterload blood pressure, heart rate. And then this other system, perfusion to the kidneys, gets decreased, which is the RAAS system is activated, and you go down this system. So eventually, though, you're going to get ventricular remodeling, and this actually starts causing, you can see the actually causes different cells in the heart wall, which causes it to be stiffer, which just continues the process, making things worse. So the key point to understanding these mechanisms in heart failure, the decreased cardiac output makes the body think there is not enough fluid in the blood vessels. Okay. Consequently, the body attempts to raise the blood pressure and increase cardiac output with unintended consequences. So we're just going to go a little deeper into the different compensatory mechanisms. So with the SNS, epinephrine and norepinephrine is released, and these here. So you get an increased heart rate, increased myocardial contraction. The heart rate's contracting faster, and your peripheral blood vessels are going to vasoconstrict. So initially, this does increase the cardiac workload. Over time, you're going to get vasoconstriction increases the preload for the heart, already dealing with volume overload, and increased cardiac workload increases the need for O2 or oxygen to the cardiac muscle. So you can see how this keeps kind of snowballing, they call it, right? This is another just slide. So this, I believe, came from, I think this is in your book, but it's a good kind of overall look at, okay, when the SNS system is activated, what goes on? So you need something like this. This is a good kind of that concept map or that mapping. The second mechanism that happens is the neurohormonal responses. So as the cardiac output falls, blood flow to the kidney decreases, and this makes it the kidney senses this as decreased overall volume, and it kicks in the RAAS system, which converts the angiotensinogen to angiotensin 1, which subsequently is converted to the angiotensin 2. And this causes the adrenal cortex to release the aldosterone. So you guys got this. I don't need to keep going through this, but basically the response ultimately is you get increased peripheral vasoconstriction, which increases the BP. And the adrenal cortex to release the aldosterone, which results in sodium and water being retained. All right. So ultimately what happens next is, with all of this going on, the ventricles start remodeling, and this causes hypertrophy of the ventricles. The ventricles larger but less effective in pumping, and it can cause dysarrhythmias. And I have a great, I'm gonna play you, oops. Okay. Now, I know on this one, I may have to fix something. Let me try this. Oh. Oh.
Heart failures.
Can you hear this, you guys?
Enough blood to meet the body's demand.
Oops.
And this can happen in two ways.
Yes.
Can't
Okay.
pump hard enough during systole, called systolic heart failure, or not enough blood fills into the ventricles during diastole, called diastolic heart failure. In both cases, blood backs up into the lungs, causing congestion or fluid buildup, which is why it's also often known as congestive heart failure, or just CHF. Congestive heart failure affects millions of people around the world. And since it means that the body's needs aren't being met, it can ultimately lead to death. Part of the reason why so many people are affected by heart failure is that there are a wide variety of heart diseases like ischemia and valvular disease that can impair the heart's ability to pump out blood and over time can ultimately cause the heart to fail. All right, so first up is systolic heart failure. Kind of a mathematical way to think about this one is that the heart needs to squeeze out a certain volume of blood each minute, called cardiac output, which can be rephrased as the heart rate, or the number of beats in a minute, multiplied by the stroke volume, the volume of blood squeezed out with each heartbeat. The heart rate's pretty intuitive, but the stroke volume is a little tricky. For example, an adult heart might beat 70 times per minute, and the left ventricle might squeeze out 70 milliliters per beat. So 70 times 70 equals a cardiac output of 4,900 milliliters per minute, which is almost 5 liters per minute. So notice that not all of the blood was pumped out, right? And the stroke volume is only a fraction of the total volume. The total volume might be closer to 110 milliliters, and 70 milliliters is the fraction that got ejected out with each beat. The other 40 milliliters kind of lingers in the left ventricle until the next beat, right? In this example, the ejection fraction would be 70 milliliters divided by 110 milliliters, or about 64%. A normal ejection fraction is around 50 to 70%. Between 40 to 50% would be considered borderline, and anything about 40% or less would indicate systolic heart failure, because the heart's only squeezing out a little bit of blood each beat. So in our example, if the total volume of the left ventricle is 110 milliliters, but only 44 milliliters was pumped out with each beat, then you have 44 milliliters divided by 110 milliliters, which is 40%. And we would say that person is in systolic heart failure. Now, in addition to systolic heart failure, you've also got diastolic heart failure, which is where the heart's squeezing hard enough, but not filling quite enough. In this case, again, the stroke volume is low, but the ejection fraction's normal. How's that? Well, it's not filling enough, so there's a low total volume, say about 69 milliliters. Well, even though both are low, 44 milliliters divided by 69 milliliters is still 64%. In this situation, the failure is caused by abnormal filling of the ventricle so that the chamber doesn't get fully loaded or stretched out in the first place. Another term for this is having a reduced preload, which is the volume of blood that's in the ventricle right before the ventricular muscle contracts. An important relationship between systolic and diastolic function is the Frank-Starling mechanism, which basically shows that loading up the ventricle with blood during diastole and stretching out the cardiac muscle makes it contract with more force, which increases stroke volume during systole. This is kind of like how stretching out a rubber band makes it snap back even harder, except that cardiac muscle is actively contracting, whereas the rubber band is passively going back to its relaxed state. All right, so heart failure can affect the right ventricle or the left ventricle or both ventricles. So someone might have right-sided heart failure, left-sided heart failure, or both, which is called biventricular heart failure, each of which can have systolic or diastolic failure. Having said that, if less blood exits either ventricle, it'll affect the other since they work in series. So left-sided could cause right-sided and vice versa. So these terms really refer to the primary problem affecting the heart, basically which one was first. Usually left-sided heart failure is caused by systolic or pumping dysfunction. And this is typically due to some kind of damage to the myocardium or the heart muscle, which means it can't contract as forcefully and pump blood as efficiently. Ischemic heart disease caused by coronary artery atherosclerosis, or plaque buildup, is the most common cause. In this case, less blood and oxygen gets through the coronary artery to the heart tissue, which damages the myocardium. Sometimes the coronary is blocked completely and that person has a heart attack. They might be left with scar tissue that doesn't contract at all, which again means that the heart can't contract as forcefully. Long-standing hypertension is another common cause of heart failure. This is because as arterial pressure increases in the systemic circulation, it gets harder for the left ventricle to pump blood out into that hypertensive systemic circulation. To compensate, the left ventricle actually bulks up and its muscles hypertrophy or grow so that the ventricle can contract with more force. The increase in muscle mass also means that there's a greater demand for oxygen. And to make things even worse, the coronaries get squeezed down by this extra muscle so that even less blood's delivered to the tissue. More demand and reduced supply means that some of the ventricular muscles starts to have weaker contractions, leading to systolic failure. Another potential cause would be dilated cardiomyopathy, where the heart chamber dilates or grows in size in an attempt to fill up the ventricle with larger and larger volumes of blood, or preload, and stretch out the muscle walls and increase contraction strength via the Frank-Starling mechanism. Even though this can actually work for a little while, over time, the muscle walls get thinner and weaker, eventually leading to muscles that are so thinned out that it causes systolic left-sided heart failure. Ultimately, the ventricular walls need to be the right size relative to the size of the chamber in order for the heart to work effectively. Any major deviation from that can lead to heart failure. All right, even though systolic failure is most common in left-sided heart failure, diastolic heart failure or filling dysfunction can also happen. In hypertension, remember how the left ventricle hypertrophy? Well, that hypertrophy is concentric, which means that the new sarcomeres are generated in parallel with existing ones. This means that as the heart muscle wall enlarges, it crowds into the ventricular chamber space, resulting in less room for blood, meaning that in addition to contributing to systolic dysfunction, hypertension also can cause diastolic heart failure. Concentric hypertrophy leading to diastolic failure can also be caused by aortic stenosis, which is a narrowing of the aortic valve opening, as well as by hypertrophic cardiomyopathy, an abnormal ventricular wall thickening, often from a genetic cause. Restrictive cardiomyopathies are yet another cause. In this case, the heart muscle gets stiffer and less compliant, and therefore the left ventricle can't easily stretch out and fill with as much blood, which leads to diastolic heart failure. When the heart doesn't pump out as much blood, there's decreased blood flow to the kidneys, which activates the renin-angiotensin-aldosterone system, ultimately causing fluid retention, which fills the heart a bit more during diastole and increases preload, which increases contraction strength, again by the Frank-Starling mechanism. Unfortunately, just like the other strategies, in the long term, retaining fluid so that more fluid remains in the blood vessels typically leads to a large portion of it leaking into the tissues and can contribute to fluid buildup in the lungs and other parts of the body, which can worsen the symptoms of heart failure. All right, so a major clinical sign of the heart not being able to pump enough blood forward to the body is that the blood starts to back up into the lungs. A backup of blood in the pulmonary veins and capillary beds can increase the pressure in the pulmonary artery and can also result in fluid moving from the blood vessels to the interstitial space, causing pulmonary edema or congestion. In the alveoli of the lungs, all this extra fluid makes oxygen and carbon dioxide exchange a lot harder, since a wider layer of fluid takes more time for oxygen and carbon dioxide to diffuse through, and therefore patients have dyspnea or trouble breathing, as well as orthopnea, which is difficulty breathing when lying down flat, since that allows venous blood to more easily flow back from the legs and the gut to the heart and eventually into the pulmonary circulation. This extra fluid in the lungs causes crackles or rales to be heard on auscultation while the patient breathes. If enough fluid fills some of these capillaries in the lungs, they can actually rupture, leaking blood into the alveoli. Alveolar macrophages then eat up these red blood cells, which causes them to take on this brownish color from iron buildup. And then they're called hemosiderin-laden macrophages, also known as heart failure cells. For left-sided heart failure, certain medications can be prescribed to help improve blood flow, like ACE inhibitors, which help dilate blood vessels, as well as diuretics to help reduce the overall fluid buildup in the body, which helps prevent hypertension from worsening the heart failure. Now let's switch gears and think about right-sided heart failure, which is actually often caused by left-sided heart failure. Okay, remember how fluid buildup increased the pressure in the pulmonary artery? Well, this increased pulmonary blood pressure makes it harder for the right side to pump blood into. In this case, the heart failure would be biventricular, since both ventricles are affected. Someone can also have isolated right-sided heart failure, though. And an example of this would be a left-to-right cardiac shunt. In these cases, there might be a cardiac shunt like an atrial septal defect or a ventricular septal defect that allows blood to flow from the higher pressure left side to the lower pressure right side, which increases fluid volume on the right side and can eventually lead to concentric hypertrophy of the right ventricle, making it more prone to ischemia, which is a systolic dysfunction, and have a smaller volume and become less compliant, which is a diastolic dysfunction. Another potential cause of isolated right-sided failure is chronic lung disease. Lung diseases often make it hard to exchange oxygen, right? Well, in response to low oxygen levels or hypoxia, the pulmonary arterioles constrict, which raises the pulmonary blood pressure. This, just like before, makes it harder for the right side of the heart to pump against and can lead to right-sided hypertrophy and heart failure. When chronic lung disease leads to right-sided hypertrophy and failure, it's known as cor pulmonale. With left-sided failure, blood gets backed up to the lungs. With right-sided failure, blood gets backed up to the body. And so patients have congestion in the veins of the systemic circulation. One common manifestation of this is jugular venous distension, where the jugular vein that brings blood back to the heart takes on more blood and becomes enlarged and distended in the neck. Also in the body, when blood backs up to the liver and the spleen, fluid can move into the interstitial spaces within those organs, and they can become enlarged, called hepatosplenomegaly, which can be painful. And if the liver is congested for long periods of time, patients can eventually develop cirrhosis and liver failure, which would be called cardiac cirrhosis. Excess interstitial fluid near the surface of the liver and spleen can also move right out into the peritoneal space as well. And since that cavity can take a lot of fluid before there's any increase in pressure, a lot of fluid can build up in the peritoneal space, which is called ascites. Finally, fluid that backs up into the interstitial space of the soft tissue of the legs causes pitting edema, where the tissue is visibly swollen, and when you apply pressure to it, it leaves a pit and takes a while to come back to its original place. This generally affects the legs in most people, because gravity generally causes the majority of the fluid to pool in the dependent parts of the body, which is the legs when you're standing, and the sacrum, essentially the lower back, when you're lying down. Right-sided heart failure will be treated similarly to left-sided heart failure, especially because it's often a result of left-sided heart failure. Therefore, medications like ACE inhibitors and diuretics might be prescribed. With heart failure, we saw that sometimes the muscle wall can stretch and thin out, or sometimes it can thicken and become ischemic. In either case, those heart cells get irritated, and this can lead to heart arrhythmias. With an arrhythmia, the ventricles don't contract and sink anymore, making them less able to pump blood out and worsening this whole situation. In some cases, patients might be prescribed with cardiac resynchronization therapy pacemakers, which can stimulate the ventricles to contract at the same time and potentially improve the blood pumped out. Alternatively, for heart failure in general, some people might have ventricular assist devices implanted, or VADs, which literally assist or help the heart pump blood. In end-stage situations, though, where other forms of treatment have failed, patients might have a heart transplant. Thanks for watching. You can help support us by donating on Patreon or subscribing to our channel or telling your friends about us on social media.
Okay. What did you guys think of that? Did you already see it once? Had you already seen that once?
No.
No.
No. I thought it was pretty good. The osmosis ones are pretty good. So it wrapped it up.
It was
very
good.
nice. Yeah, wrapped it up very nicely, I thought. Okay, so next I would like to, and let's see if this works, go to our Google Doc. No, that's not. I think I've got to put that in your, okay, Emily and Aaron, do I just put that in the chat area? The link?
Yeah, you can just put the Google Doc in the chat.
Okay, let me go back here. I thought I had it. Let's see. Oops. Yeah. All right. Sorry, guys. Let's see.
Recording in progress.
Copy link address. Let me go back over here. Where did you guys go? Why is it not letting me? Let me see here.
I put it in the chat. I think everybody's starting to get into it.
You did? Oh, cool. So basically, I need to put it up on screen for you guys, though. Let's see. Sorry, guys. So one of you have it. I wonder if I let you, because I'm having trouble figuring out where to find it now. Do you want to share it, put it up as a shared screen? Can you do that? Are you able to?
It looks like it says that with you already sharing your screen, we can't share our screen.
Oh, okay. So I need to stop share. Okay, there you go. Do you have it, Hugo? There you go. Good. All right, so we're going to start with just and then I'll let you guys go for a quick break. But so let's see. So Hugo, you're going to have control over this then, right? So we're going to go down to Mr. Morales. He's 50 years old. He's a middle manager for a San Jose computer company. He is married. He has 4 kids, and they range from 13 to 18. He works long hours, rarely getting home before 8 o'clock. And 2 years ago, he was diagnosed with coronary artery disease after experiencing chest pain. He did suffer an MI 8 months ago in the anterior wall of the heart. Since his heart attack, he has reduced his work hours slightly. However, he remains sedentary, continues to consume a high-fat diet, and smokes 2 packs of cigarettes per day. And he has a BMI of 32. So let's see here. Let me just go. All right, so that's kind of our introduction. I don't know how well this is going to be. Let's see. Let's take a 5-minute break. Is everyone still there? I'm going to set the timer for 5 minutes and then we'll come back, okay? Okay. All right, so everybody can see now. I did go to the link, so everybody can see it on the big screen now, or let's see.
I think you have to share it still.
There we go. All right, so you can see now?
Yes.
All right, so let's just start on this, and then I'll go back to our PowerPoint. So we have Mr. Morales, and today he's come to the clinic where he's telling you he doesn't feel well. During your assessment, in his interview, he tells you that he's been more tired than usual, has gained 6 pounds within 2 weeks. So these different things, I'm not going to read them all. I want you guys to start, I don't know if you can do this, like highlighting things that are jumping out to you about him that are concerning. Good. Good. All right, so the first question is, what assumptions are you making about Mr. Morales? What assumptions did you make? So I was kind of thinking, well, he's asking for the quote unquote water pills, so he must not be taking his medication, right? Or at least that particular one. Oops. Are you guys putting it in there? There you go. So Grace put non-adherence to the medication. Claudia, sorry, is he works long hours. So when does he have time to do any kind of exercise, right? No time for family. What else? Anything else? Is what you're seeing on him, are you concerned? You can verbally answer that too.
Yes, definitely
Yeah.
the weight gain.
Right. The weight gain, his respirations being 32 per minute. What's going on with the crackles? What's that telling you? After we just saw that video and we talked about it, what is that telling you? What's that?
Do you have a buildup of fluid?
Right, he's getting fluid that's backing up into his lungs and his heart. So things aren't going so well. And that kind of answers our next question, right? What's our initial impression of his health status? I think we've kind of said not great, right? He's let's see, recent MI puts him at risk for heart failure due to weakened heart contractility. Good. deficit of knowledge. Armel, you want to expand on that?
Yes, Mrs. Top. I feel like maybe he doesn't have enough information about how I don't know how bad is his health at the present time, you know.
Good, yeah, exactly.
Lacking for exercising, for not like complaining to the diet and his medication. Maybe he doesn't have, you know, all the knowledge to really take care of his health.
Good, good, yes. And that's something as nurses we can help with, right? So what do you think our priority is with him right now? You can write it as when people can talk. What do you think our priority is? He's standing right in front of you. What would be, you just took his blood pressure, it's 180/110. He's got, pardon me?
Safety.
Okay, who said that? Alfredo. So safety, what are you thinking?
He's gonna pass out, or he could possibly pass out.
Okay, so what do you want to do to help him not pass out?
You want to sit him down, assess him, oxygen, interventions, you know, set him upright.
Yeah, so he's probably not going to be comfortable laying flat because of that fluid that's in his lung, that's in his lungs. Maybe get his legs up, have him be more in a semi-Fowlers or low semi-Fowlers. I'd want to talk to the doctor about his blood pressure, right? Get that down. I don't see a O2 sat here, but the assumption is his O2 sat is going to be low. So yes, you might want to stick some oxygen on him. Again, that's one of those things that, you know, depending on what he looks like standing in front of you, and I would get the doctor to come in, obviously. And with the occasional irregular beats, what is that telling us about his heart failure? Yeah, heart rate is up and irregular beats. Hugo put that. So Hugo, when you wrote that, what is that kind of telling you about his overall condition also?
Well, I mean, obviously he's having irregular beats, so his heart is not happy with what's going on. I think that the heart rate is going to be up because the BP is so high. It's trying to, I think they're both kind of contributing to each other, but ultimately I think that there are some blood pressure meds that we might be able to give him that will have the chronotropic and the the inotropic, I think it is, effect to try and get the BP down, get the heart rate down. I think the irregular heartbeats are happening because his heart rate is going so fast and probably has been sustained for so long that the contractions are starting to almost kind of bleed into each other, you know?
Yeah, his heart's not able to fill like it should be, right? It's not getting that diastolic phase. To me, looking at all of these vital signs, this has been going on. If he gained 6 pounds within 2 weeks and he's got 3+ pitting edema, he's now got this fluid in his lungs when he tries to breathe, he feels lousy basically. This heart failure definitely isn't, it's kind of now more chronic, right? I mean, this didn't just start a few days ago. Let's see. I can't see the chat. Did someone put something in the chat? I didn't see what it said, but
could you call it compensation since his body is no longer able to like do what you.
Say that again. Was that Brittany?
Yeah, I was just asking, would you call this decompensation since
Yes.
he's not? Okay.
I would. I mean, his body, to me, his body has tried all those compensatory mechanisms that our AAS system's been activated. He's his heart rate's tried to increase. He's, you know, done all of these, the body has tried to do all of this stuff. Now it's starting to decompensate. And if we don't do something for him, like the meds, like Hugo was saying, and lifestyle changes, diet changes, if we don't do something, he will, he's going to just get worse, and he's going to die. I mean, so this is an extremely important appointment. Then over here, we talked about clustering his clinical manifestations. And mind you, I know I looked at this and I thought, well, I know that's not really what concepts we're calling them from Giddens, but you get the idea, right? So activity, his sedentary lifestyle, the foods and food and fluids, his high fat diet, probably a high salt diet is going on also. Respiratory wise, again, the respiratory rate being 32, labored, he's not feeling well. That means back to, he's not getting oxygen to his central, he's not getting centrally perfused. And good, the circulation, we said, the 3+ pitting edema, the high blood pressure, and his heart rate. So good, you guys are right on. And let's see up here, Armel said, position the patient, maximize ventilation. Yes. And get his legs up, right? And work on getting the heart rate down. He's probably, and we'll get into that. What kind of, just offhand, what kind of lab work and stuff are you thinking he needs to have done? What do you want to know?
ABGs.
Yeah, I want to know. Yes, Brittany. Or was that Shannon? Yeah, I'd want to know ABGs, his ABG. I'd want to know
like a CBC and a BNP.
Yeah.
The
And
cardiac
a
enzyme.
CBC, a BNP, and remember the BNP, right? With an N, BNP. John, what did you say? Did you say something?
Cardiac enzyme.
Cardiac enzymes, maybe.
The troponin
Yeah.
test.
Say it again.
Troponin.
Yep. Troponin, BNP, CRP. I don't know if they do CRP as much, but yes. Yeah, we want to know what's going on. Did he have another MI? He could have, right? So he is, now we are going into the hospital setting. Now I'm going to kind of pause on this part. We'll see if this works, okay? So, and go back to, can you see my PowerPoint slide?
Yes.
Okay, so heart failure in just the incidence in the United States. 6.5 million people in the United States have heart failure. And it's the most common reason for hospital admission for people and people over the age of 65. And it's more common in African American individuals under the age of 50 than in Euro Americans. Now, there's lots of studies out there. Why is that, right? Is it, trying to, is it access to healthcare? Is it diet? Is it both? Is it there's all sorts of studies going on. So when we are looking at cues, and that's where we looked at in the first part with the case study, we're looking at what was his history of heart condition, his activity intolerance or tolerance, and breathing, sleeping, and urinary patterns. So left ventricular failure. I'm just going to put this slide up and you can kind of look at it and think about this. So we know decreased cardiac output is going on. He has fatigue. He has weakness. He hasn't talked about having oliguria, but do you remember what oliguria is? I don't want to use these words that you guys don't remember. So oliguria, boy, is a very small amount of urine is going out, okay? Any kind of heart pain, angina, is he confused? Is he restless? He's kind of like snippy with you. Tachycardia, palpitation, he has all of these, right? Going on. He has the hacking cough. He has crackles. He didn't talk about frothy pink tinge sputum, but I'm sure that's coming up soon. Okay, so left-sided failure again, and this is just a cute picture to help you remember, okay? Right ventricular failure. Again, if you go back to the osmosis video that we saw, talking about, think about it's not backing up into the lungs, it's now backing up into the body, right? So that's where you're getting systemic congestion, the jugular vein distension, the enlarged liver. He's not feeling hungry. He's got the dependent edema in his legs. And here you're getting polyuria at night. So once his body relaxes and he's laying flat, he is having to get up and down to go to the bathroom. The weight gain, increased blood pressure. Okay. Let's see. I put a few of these slides through this slideshow because it goes back to that safety. And I think it was it Alfredo who said safety? Someone said safety. So priority, nursing safety priority, okay? Action. If he's got edema, it's an extremely unreliable sign of how bad his heart failure is, but taking a daily weight to document the fluid retention is going to be important. So assessing his weight at the same time in the morning using the same scale is going to be important. Now, in the hospital, it's probably going to be with the bed, right? So, and that's kind of back to a first semester thing. So weight is the most important reliable indicator of fluid gain or loss. So recognizing cues, we've got lab work and we talked a little bit about that. We didn't even say electrolytes, right? What's his sodium? What's his potassium? What is his electrolytes? What is his H and H? The B and P. Urinalysis, ABG, chest x-ray, okay? But an echocardiography is the best tool for diagnosing the heart failure. And that's because we want to know what, and they talked about it in the video and I talked a little bit about it earlier in the lecture. What do we want to know about his heart? What do you think?
The ejection fraction?
Yes, yeah, the ejection fraction. Because remember, that's what they use to diagnose it, right? So with electrolyte imbalance, so they may get into some problems with electrolyte imbalance because they're not taking their medication correctly, right? So if they're taking diuretic therapy, which Mr. Morales has some diuretics he's taking, Regular evaluation of the serum electrolytes, which includes the sodium, potassium, magnesium, calcium, and chloride, are an essential part of care for him. Any kind of renal function, which results in the inadequate perfusion. So you're looking at the BUN and the serum creatinine. And we're looking at decreased creatinine clearance levels. What's his H&H? And then the one thing I wanted to touch on was the BNP, N as in Nancy, P. This is used for diagnosing heart failure, in particular for diastolic heart failure, and in particular with patients with acute dyspnea, difficulty breathing. So this is the body's response to the decreased cardiac output from either side, from either left or right. An absence of the elevation in the BNP in conjunction with the history and physical rules out heart failure as the cause for acute dyspnea and points to a primary lung problem. So in the ambulatory care setting, BNP trends may be used over time to guide the care treatment of this patient. This is just a X-ray showing you the enlarged heart, and they look at the heart size, the changes in the different chambers. The chest X-ray can record displacement or enlargement of the heart. And you can see fluid around the heart and any kind of pulmonary congestion. I'll tell you something that happened to my dad probably a few years ago. Was he was having trouble breathing, and he didn't really have congestive heart failure, but they couldn't figure out what was going on with him. They kept saying he had pneumonia. And it wasn't until they did do a chest X-ray, and it must have not been clear enough, but eventually they took a chest X-ray and they only saw a small amount of fluid. So they were saying, yeah, he has a little bit of fluid around his heart, but that shouldn't be causing his difficulty breathing. When they finally decided, well, we can't figure out anything else that's going on, so we'll go in and pull that fluid off his heart, they got almost a liter of fluid off his heart. So and obviously that would have caused problems with him breathing. So just one side note on here though, these are some things that they'll do for the hemodynamic monitoring. So what are we paying attention to for this client? So you've got the PAP, or positive airway pressure, and you've got the PAWP, which is a pulmonary artery wedge pressure. This is stuff you're going to see in ICU, obviously, correct? But no, an ECG is not going to really show you much, right? It's not really helpful in actually determining if this patient has heart failure. If any questions? Are you guys good? So, question. Clients diagnosed with left-sided heart failure, which client assessment findings will the nurse anticipate? So he's got left-sided failure. You can write on there if you want, I think, can't you, or no? Good. Good, yep. Correct. So it's going to be crackles, tachycardia, tachypnea, and the S3 gallop. Good, guys. So this could very well be some sort of test question, right? Something like this, because what it's telling me is that you understand the difference between left and right-sided heart failure. Okay, what are the assessment findings that you would see? Okay. I don't know how. Let's see. Oh, here we go. Okay. All right, let's go back to our Mr. Morales, I think. Let's see. Oops. Oops. Okay. So these are some, if we're gonna write some of your nursing diagnoses, it's kind of weird for me to keep calling it nursing diagnoses, but conceptually, what are we thinking? So they have decreased gas exchange due to our ventilation perfusion imbalance, okay? Potential for decreased perfusion due to inadequate cardiac output. So potential, this is the same as that at risk for, right? So when you talk about potential, you're saying due to left-sided, I would put even related to, because you don't have evidence to put there, okay? All right, let's go to our next one. So here, I probably should move our screen back, huh? Move this back so you guys can better do it. All right, so cluster, no. So the next day you are now the hospital-based nurse. You review data from the previous day's admission records in the ER documentation. Mr. Morales was given 40 milligrams of IV of Lasix ×1, and then at 2 in the morning, and because the bilateral crackles, they gave it because of his bilateral crackles in his lower lobes and his difficulty breathing on exertion. So the question is, would you use the bell of the stethoscope or the diaphragm to auscultate his lung fills, and why? You can verbally tell me this or write it or whatever you want to do.
It'd be the diaphragm, wouldn't it?
Why?
Well, because the bell is used for low pitch sounds and we're listening for crackles, which are going to be the high pitch sounds.
Okay, what does everyone else say? What do you think, guys?
How about using both?
Well, you could, but why?
I would use the bell side because it can pick up the low pitch sounds, which would help you hear the S3, S4.
So you're thinking in terms of for the heart sounds. Okay, but so
for his lungs. Oh, okay.
The diaphragm though, so let's first figure out, is it the diaphragm that's high pitch sounds, or is the diaphragm low pitch sounds?
The diaphragm should be high pitch. I believe the bell is low pitch, which you would want to use to listen for the crackles.
Yes. Yeah. Okay. I mean, obviously you can flip it back and forth, but if you're specifically listening to the lungs and you want to know what the lung sounds are, yeah, I would probably go for the bell. Honestly though, on a lot of times, oh shoot, I knew that was going to happen eventually. Okay. Just sorry guys, and I don't know where to. Okay. So Does someone want to write that in there so that we have that right? So, so does anyone have anything different to say about that? I mean, you can all,
I mean, I've always been told that crackles they're always defined as high pitched sounds. So I like Hugo would say the other side.
okay. What do you guys think?
I also agree that I think I remember learning that crackles were high pitched.
So what so you're saying they're high pitched, so you want to use,
Would it be dependent if they're coarse crackles or fine crackles?
if they're fine crackers? Yeah, because they can't crackles. Yes, that's true. As there's more fluid in there, it's obviously going to sound different. So I kind of think crackles initially are high pitched also. So what did you want to use? Again, this isn't necessarily, what did you want to use, you guys? Oops, I keep losing my chat. I want to see the chat. This is where you get it, you get it right here, guys. Okay.
Honestly, I think you can, unless you're actually hearing it, because I've listened with both sides sometimes and I can hear it. So it really whatever works for you, to be honest with you.
And it doesn't hurt to use both, right?
Mrs. Thorpe, what would you recommend?
I kind of tend to go for, I think I'm going to go for more the bell for initially. To me, the bell I use for high pitch, the diaphragm for low pitch. But again, I think I've got that switched, huh? Sorry,
So I've
guys.
looked it up in a couple of different places, and it looks like there's a differentiation between fine crackles and coarse crackles.
Yes,
and
there is.
Coarse crackles can be more of an indication of pneumonia, whereas fine crackles are an indication of edema, and that fine crackles are more high pitched and coarse crackles are more low pitched. So in this case, because it was edema that we're looking for, and we talk about fine crackles for those are going to be high pitched. So I would use the diaphragm. That was the logic that I used.
So I'm seeing though that the bell is best for lower pitch sounds.
Right, and coarse crackles would be low pitched, and those ones are usually more associated with pneumonia.
Coarse crackles are low pitched with pneumonia. I have a slide on this too. So that lower pitch would be The diaphragm, no, the bell. Okay. God, I'm getting myself confused now, you guys. Okay, so we said we're going to use the bell because we're assuming these are going to be lower pitched. Is that what you're saying? So who wrote this? Armel, is that what you're saying?
Yes, I did, because I was thinking, to use the bell to hear for the crackles, but I didn't know the difference between fine crackles was like related to like heart failure, and then cause was related to pneumonia. So
well, and you can have it changing too. So if we say the bell is used for detecting low pitched sounds, right? And the diaphragm is used for high pitched. Okay, and we're feeling like, I kind of think it's going to be more lower pitch, but I guess you, like you're saying, you would use both. Yeah. What the question is asking you is basically just give a reason why you would choose that, right? So if we say, Armel said she would use the bell because she wants to hear it for low pitch sounds. Let me go on here. Let me go over here because I have a slide. Let's see.
If we put the opposite of what, I don't know what you're looking for, are we going to get docked wrong for that, or?
No,
Okay.
no, but you might want to go back and change it if you're using it as a
Study guide?
As a study guide, right? Like work through why you would do something. So then if we go down, let me just do one more thing. Okay, let me just, while we're on this. So here's, I found this one and I thought this was really good, you guys. So we're gonna probably hear his, I think that they called them coarse crackles, didn't they, on here? Yeah, bilateral, no, they just said bilateral crackles in the lower lobes. So can you see this slide?
Yes.
So what I would do, you guys, I would go off this slide, because if I'm going to pull anything for any kind of test question, I'm going to go back to this slide, because I feel like this is a very clear, clear look, right? So if we go according to this and we say, let me just go back here. So if we say that these are going to be fine high pitched or medium pitched, then both people would be right, right? You could use the bell and the diaphragm, because we're going to use the diaphragm when they're here. We're going to probably hear them better when they're in this area. But as the condition is worsened, and he probably is worsening, we said, then you may need to switch over to the bell, right? No, I'm sorry, to the diaphragm. Oh God. To the diaphragm. Does that make sense?
Yes.
Okay. So to me, this is really, really a good slide here. So it says crackles may be heard for pneumonia, congestive heart failure, chronic bronchitis, asthma, and other restrictive or obstructive diseases. You get into wheezes for asthma, rhonchi, could be some sort of obstruction in the trachea or the bronchus. All right. And then this pleural friction rub is something more, probably, it's going to just sound differently. A grating sound, they call it. All right. I don't know if you need this, but it's not. Okay. So late inspiratory crackles can suggest pneumonia, heart failure. Okay. So when we're planning and implementing, so this is what are our interventions? What are we going to do here? So we're planning. So we need to increase perfusion, really increase perfusion, increase gas exchange, and prevent or manage any kind of pulmonary edema that might go on. Our increasing gas exchange problem, our expected outcome are going to be the patient will have an optimal spontaneous breathing pattern that increases his gas exchange and maintains a serum CO2 level that is within normal limits. And then our interventions are going to be here, the ventilation assistance that may be needed because his oxygen content in his blood from looking at his ABG is decreased. Monitor the patient's respiratory rate, rhythm, and quality from 1 to 4 hours, and auscultate his breath sounds every 4 to 8 hours. For planning to increase his perfusion, our outcome, we want the patient to have increased perfusion with adequate cardiac output. This is going to be a collaborative interventions, right? And we're going to want to look at non-surgical interventions, and that's going to be drugs that reduce the afterload, angiotensin angiotensin converting enzyme inhibitors and angiotensin receptor blockers, and then some other interventions that reduce the preload, nutrition therapy, and more drug therapies. So let's go back to our, let's go back over here. Oh, so our breathing pattern thing didn't get in there. Where then would you say you're going to hear the crackles on that graph?
It was towards the end of their breath in.
Towards the end on their inspiration. Yeah. So yeah. So it's just before you get to the peak, right? Everybody got that?
Yes.
Okay, so based on our principles of pharmaceutics, I can say pharmacokinetics and pharmacodynamics, and how they would evaluate for, how would you evaluate the LASIK's effectiveness? And we've gotten, so the onset is in 5 minutes. Yes, LASIK works very quickly. They reduce intracellular and extracellular fluid volume. Thus, it helps reduce the blood pressure and cardiac output and decrease cardiac output because you're getting rid of the fluid in the system, right? Monitor the blood pressure and BUN, BG, serum creatinine, electrolytes. And why would you look at the BG, the blood glucose? Why do you think you would look at the blood glucose? I mean, I'm just curious why someone put that. It's good. I mean, I would make sure also hepatic function. I would make sure you're putting the BNP was something there too. Okay, so as you walk in the room, the patient's room, to complete the morning assessment and to get his O2 sat value, he says, please don't bother me. I was up in the bathroom every hour last night and I have no energy and I want to sleep. So let's just talk. We don't have to go through every single question here, but tell me what you would do. What would you do for him? Is he just being obstinate? Is that what you say? And he's just being difficult? Is it worrisome if he hasn't slept?
Oh yeah, but obviously if he's had the LASIKs, he is going to be going up, getting up to go to the restroom. So, I would have just explained to him that, I understand, obviously you want to justify his statement, understand, he's, here, let me read to you what I actually said. It's not coming out like it. I said, Mr. Morales, I understand your frustrations and know you must be feeling worn out from the constant interruptions, from rest to go urinate. The oximeter will measure your oxygen levels, the oxygen levels in your blood plasma, and ensure your body has enough O2 to keep your body's organ systems working. Plus, it will only take a second, and it is very important to monitor these levels. And then I said, may I go ahead and take your O2 levels?
Okay, so that's good. What else could you add to that?
I said basically the same thing, or our group said basically the same thing, but we added in there information that, his the LASIKs that he's taking is going to cause that. And then maybe that would kind of trigger him to ask more questions about it. Maybe you can do a few minutes of patient teaching or whatnot while you're, obtaining those assessments that you need. And then informing him also that we can, we're going to try to cluster his care as much as possible, but, for the moment, it's our job to make sure that he's in a, substantial state where, he's okay, and get a baseline of him first.
Good. So yeah, and I heard you say that about clustering care. So yeah, giving him some quick education. He's exhausted. He doesn't want to hear a whole lot, but if you can give him the short and sweet of it and then explain to him, I almost would bargain with them and say, if you can let us get these things done in the next half hour, I'll make sure that I put a sign on the door so you can get an hour and a half sleep, or 2 hours of uninterrupted sleep. Something like that, right? So what they want to know how you would write the description of the incident down here. I don't know that that's totally, but offhand, did somebody put something down that they're like, I really like this? You can type it in, or so I personally, I think I would jot something to the effect of
I'll read what I wrote.
okay.
I said, entered patient room to obtain SaO2 reading with pulse oximeter. Patient stated did not want to be disturbed related to continually going to restroom every hour throughout the night. Previous admin of furosemide 40 milligrams via IV infusion at 200. Educated patient of importance of O2 level readings, will continue to monitor and re-educate patient after rest period.
Good. What do you guys think? That sum it up?
Yeah, pretty much. It's just important to document what he states, but then also what you did, and
Right.
the patient presented. You want to cover your butt as well.
Yeah, yeah, and you could also, you could document your education in there and all of that. Not in your long nursing note, but somewhere there's usually a spot where you chart education, right? So what do you think is the relationship between his making sure he has energy and oxygenation? What's that relationship? Somebody have a guess?
I'm happy to read what our group put, so that way there's not awkward silence. Just give me a second
Okay.
to pull it up.
All right.
It says encouraging energy conservation by assisting with care and patient ADLs. Ultimately, heart failure results from the inability of the heart to pump enough to meet the energy needs of the body. Reducing the energy needed for the body to function can help decrease the output of the output the heart would need for the movement of oxygen throughout the body. Cardiac output is the product of the heart rate and the stroke volume. An increase in the heart rate would cause an increase in the cardiac output, which increases the oxygen demand from the myocardium.
Good. Excellent. Yep. Okay. And then the last part of this is kind of talking about who could you and this is important, but we don't need to spend class time doing it. But just thinking about who does what interventions, how can you delegate, how can you make this care more streamlined, and bringing people together and figuring out how to actually do this. And let's just talk about this organizing care. So they want you to do a timeline between 7 o'clock and noon, listing how you could do these interventions in who you would have perform them. But I'm more interested in how you came up with a way, because I noticed some people did, a way for the client to have some sleep.
I think it's just most importantly, like you want to just cluster the care. So after you get them up and give them some breakfast, you want to kind of provide a few interventions when they're awake and alert and willing to do some things, as well as allow him to rest a little bit while maybe you do the central line dressing change. And then from there, after that, he'll be able to have a few hours of rest before his next, like between the time of his med pass at 10 and his noon vitals.
Yes. So I think, yes, exactly. So that this stuff, this AM care and stuff really needs to be done. You know, you have 8 o'clock and 10 o'clock meds. So you could kind of scrunch everything in and do, maybe get your meds done, you know, you could do 7:30 and then 9:30, right? You could do the half hour before, or you could pull these apart and give that at 10:30, give those early and have that block of time for him in the morning to get some sort of little sleep, even an hour probably. But some of this other stuff, you could probably hold off venipuncture for blood studies unless it's something specifically that the doctor has said, no, I need it now, which a lot of times they do need them in the morning. So you may have to get the lab to come up before you put the sign up on the outside of the door saying don't disturb, right? The vital signs things, I mean, again, is there ways that you can push those half hour one way or another to allow that time? What else does, in the incentive spirometer, I think, you know, 1 hour may be something that you just don't have him do it for that hour. I mean, he's got to have some sleep. But that's my thoughts. What else? There was something else I was going to say. So a lot of these things, basically, what I want to say is that we as nurses are the gatekeeper to this client's care. All right. As the RN, you're the one that says, no, let's hold off on the portable chest x-ray until 9:30 or 10 o'clock, because he has 10 o'clock meds. We're going to go in there anyways, see if they'll come up and do the chest x-ray then. Do you see what I'm saying? I mean, and the interesting part of this is that even though this is obviously adult care, this translates to many areas of the hospital, okay? The whole, you keeping, you know, that's extremely important. The conservation of energy, he's going to use more oxygen. Okay, let's see.
Mrs. Thorpe, just a heads up, we're at 12:56.
Sorry, yeah, you're done. Okay, I think we pretty much went through there. Don't worry about surgical management. Look over the pulmonary edema, just understanding how to, you know, the priorities for that and what it means. You know, these different things I've put on here, guys, with the CUSIN, nursing safety priority, they're in your book. Look at those. And I think that's probably it anyways, okay? All right.
Thank you, Ms. Thorpe.
You're welcome. Hopefully everybody got questions answered. If you have questions, just let me know. Let's see, be at the hospital tomorrow. So someone's asking, Emily's asking about a hospital tomorrow. Since they weren't, do you have, I will check on that, you guys. It looks like there's something going on about that. Last week, they thought possibly we would be kicked out for the week. It's going to be for both days if we do. I have planned for my group something, and I think they've already got something planned for the ARU group, but we'll keep you informed, okay?
We have a message that already went out regarding clinical tomorrow and Wednesday. We're going to be at alternate sites.
So they already heard, because I didn't get.
I got a message on the Google Hangouts for clinical groups for Miss Dupree's group. For ARU, it says Tuesday. Let's see. Sorry, I'm trying to pull it up. It says, good morning and happy Monday to all of you. There will be a change of time and location for our clinical rotations this week due to Natividad Expecting Joint Commission site. And then it says for Isaac, Aaron, Grace, Nick, Myra, and Brittany, they'll be joining the VNA at the VAC clinic tomorrow in Salinas from 1:30 to as late as 7 o'clock or as late as 6 o'clock. And then for Wednesday, multiple of us, Loida, Mary Cruz, Grace, me, John, Liz, and Brittany will be going to Gonzales for a VAC clinic. So check your Google Hangout. There should be a message there.
Yeah, and that all had to do with your group, right, Shannon?
Yeah.
That did not have to do with ours. So my group in particular, because the maternity group has more hours going as direct hours because we can have more people. So a lot of times we have more hours already. That being said, I have something planned for Tuesday I need to figure out for Wednesday. The Tuesday is going to be a VSIM. All right, so I will get back to you times and everything, guys. Thank you.
So does that mean we're not going to be in the hospital and we're just going to do the VSIM on Zoom together?
Correct.
Okay, so
Now,
tell us later
I
times.
hope I might be able to get us into the school, which might be nice, or maybe the school on Wednesday. So maybe we could do some other things, hands-on stuff, or, you know, actually still do something. So we'll see. Okay.
Okay, thank you. We'll be waiting for your message. Thank you.
All righty. Okay. All right. Bye, guys. But those of you who have SIM already scheduled, stay with the SIM. Okay.
Should I go to Sim then?
No, who is this, Francisco?
Yeah, sorry. Because
no,
you had messaged me Friday.
No,
to go to the
Sam, you were
hospital,
gonna be with me at the hospital, so you're gonna be with me for VSIM. Okay, because I don't want to screw up your schedule because I have you at SIM at the end then.
Okay, thank you.
Okay. All right, guys.
Mrs.
Thank you. Yeah.
Could you a minute?
Yeah, who is this?
Francesca.
Oh, Francesca, just a sec. Let me go over here. Let's see. Okay, let me see. Francesca, just a sec. Let me put you back over here. Did everybody leave? I can't tell. I don't know why I can't tell what's going on here. Let's see. Let me stop the recording too, okay?
Okay, thank you.
Where is my record? Oh, here we go.